Are we live?
Should we wait for a couple of minutes?
Ma'am, we are just about to. Yes, ma'am, we are live.
Sir. Sir.
Hi, am I audible?
Yes.
So I would like to invite our panelist, Dr. Sourabh Sharma sir and Dr. Shrikant Gundlapalli sir for this session. And the talk will be delivered by Dr. Girish Kumthekar sir. Dr. Girish is head of the department at Symbiosis Hospital, Pune. He is also a consultant nephrologist with the renowned group. And I know Girish sir for last 16 years minimum, and he is a pure methodical researcher kind of a person. Those who has like met him for even couple of minutes, he has like lucky enough to impress them with his charm. So I would like to invite him for this talk, and we'll start right away. Thank you, sir.
Thank you, Suhas, for the very kind and profuse introduction. So I'll just straight away try to share my screen and we'll discuss about HemoDiaFiltration today. And we are trying to focus on the concept and the connectology. So we are talking about the concept and connectology today. So let us begin. I hope my screen is visible.
Yes, sir.
Okay. So I will be talking about hemodiafiltration concept and connectology. So first, I will just take you through the evolution of hemodiafiltration. Initially, when we were talking about extracorporeal removal of uremic toxins, we were content with only diffusive mode of removal of these molecules. But at the time came when in 1967, we thought of let us start with hemodiafiltration to infuse some amount of substitution fluid in the circuit and just try to get as much as ultrafiltration as we can, and it was a standard hemodiafiltration, and then it has evolved to online hemodiafiltration in early 2000, in early 1998. After that we have seen a lot of development, and now we are talking about not only diffusion, not only convection, but also adsorption also, to remove the uremic toxins. So these three modalities put together is what hemodiafiltration is all about. So our quest is to remove the harmful metabolic substances in a patient having uremia. And these are mainly the low molecular weights, the middle molecular weights, and the high molecular weights. And if you look at the spectrum, the low flux modality of dialysis will take care of only the low molecular weight toxins. But the symptoms are not only because of the low molecular weight toxins; they are because of the middle molecules and the high molecules. So we need something that will take care of these molecules, and that's where the hemodiafiltration fits in. Lot has been done in the hemodiafiltration modalities. We have multiple data, and all these RCTs and the studies, they have compared hemodiafiltration with not only low flux hemodialysis but with also high flux hemodialysis. And most of, if not all, these studies have shown a survival gain of say more than 18 to 35 to 40%. So that is what we are more interested in hemodiafiltration as a modality for maintenance hemodialysis, or what we can call as a chronic dialysis. These things came into vogue after the L-Tox trial, which was published in 2003, which spoke about the convective dialysis dose. So when we think like, okay, we are okay with putting some fluid in the as a substitution fluid, take it out in the hemodiafiltration, but the question comes: what dose, what molecules, what connectology, and should be the prescription of these methodologies? And that's why we now started talking about comparing these three modalities and seeing what is the difference in these three modalities: the low flux hemodialysis, high flux hemodialysis, and all round hemodiafiltration. So basically, what we need for hemodiafiltration is a highly permeable membrane, which is a high flux membrane. The high flux is it is 20 the ml, which is per minute change in the transmembrane pressure, which can withstand that much amount of ultrafiltration. We need a very high quantity of dialysate fluid as well as a very high quality of dialysate fluid. So we need ultra pure water. We need a dilution, which could be post dilution or a pre dilution. The pre means before the dialyzer, post means after the dialyzer. So there are multiple permutations and combinations, and that results into something called as a hemodiafiltration. So this particular slide will tell you the difference between classical HDF and the online HDF. In classical HDF, we are getting the substitution fluid directly from the bags. And in online HDF, as I can highlight here, the substitution fluid is generated by the machine with the help of two filters which are fitted in the back of the machine, which generate a sterile substitution fluid. And let me tell you, this is the only occasion where we infuse a fluid into a patient before testing it in the labs. So that surety we have that the substitution fluid will be a sterile fluid and compatible for infusing in the bloodstream. So this is online hemodiafiltration. So the supply of substitution fluid is unlimited. As long as you have ultra pure dialysate going on, we'll have the sterile substitution fluid. So we can run this therapy for n number of hours and with whatever dose we want. And this is the modality of substitution. We can have a post dilution where the substitution fluid is infused after the dialyzer, and pre-dilution, which is before the dialyzer. I want to highlight the difference between the CRRT and SDF here. In CRRT, we talk about pre-blood pump dilution. But in HDF, there is no pre-blood pump. It is always before the dialyzer. It is not before the blood pump. The infusion happens something between the pump and the dialyzer. So this is the principle of hemodiafiltration. The total clearance is equal to the diffusive clearance because we have a dialysate fluid running across the membrane. Convective clearance because we putting the substitution fluid and taking out in the as a convective dose, and adsorptive clearance. So all these things put together, we have a very efficient modality of extracorporeal blood purification. But what is the bane of this hemodiafiltration? And that is the quality of water. So unless the water has a least amount of contamination level, it is difficult for us to run a hemodiafiltration machine. So the focus is on the prescription and the machine, but the equal focus needs to be put on the quality of ultra pure water generated by your RO plant. We have multiple machines in the market. We have Fresenius 5000S, we have B Brown Dialog Plus. These two are basically the machines which are used by most of us, and they really work nice. And these are the evidence which I would like to highlight. This is basically European evidence. We are just trying to extrapolate what they have done to our country. And these are all studies showing it is much superior than hemodialysis. And these studies have not only looked into they are not only the observational studies like DOPPS, they are randomized controlled trials. And these randomized controlled trials have used some kind of switch over methodology. Like for 4 months, people did hemodiafiltration, then they switched the patient to hemodialysis, and again to and fro. And they found benefit, even though this is a very robust clinical model, and there are meta-analysis. But all these things, they were not unanimous on what amount of convective dose we should deliver. So the DOPPS found that the convective dose varies from country to country. Like the Japan, they are happy with a convective dose of 15 liters per session. But if you go to Australia and New Zealand, they are giving a dose of 30 liters per session. So the variation is across the country for the convective dose. Then people talked about what is the safety of long-term use with the help of bacteriometry and endotoxin assays. So it was super safe to use a substitution fluid for infusion into the patient bloodstream. And this purity was confirmed in more than 99% of samples. so that the two filters which are fitted in the back of the machine, it is capable of generating a safe fluid for infusion into the bloodstream. Is hemodiafiltration only useful for removal of uremic toxins? The answer is no. It is much more than that. So this we can extrapolate that the inflammatory markers also go down because of the removal of the middle molecules. The pro-inflammatory molecules are gone out. The other molecules are going out because of the hemodiafiltration. Similarly, it causes cardiovascular mortality reductions. Because of low inflammatory load and convective volume, the hemodynamics are stable, so less cardiac stunning. So it's better for cardiovascular safety. So that's why it's not only a reduction in the mortality. Now we are talking about reduction in the intradialytic hypotensions, episodes of stroke, episodes of cardiovascular mortality, and most important, reduced rates of hospitalizations. But that is not enough. Hemodiafiltration scores in nutritional aspects also. So people who are getting a hemodiafiltration, they have more better nutritional status than somebody who's getting hemodialysis. It also helps in reducing the phosphate. So it has beneficial effects on the mineral-borne diseases with the phosphate going down. And it is proven when we switch the patient from hemodialysis to hemodiafiltration and to and fro. So hemodiafiltration not only talking about the middle molecules, it is talking much more in benefits in this category of patients. So survival is definitely higher, and this is what we are talking. We are advocating hemodiafiltration for maintenance dialysis. So let us revisit this slide one again. So this slide prompted Dr. Ronco to write this paper, and he talked about the dose of the hemodiafiltration in very great details, and he found out a magic number of 23 liters. So once we go beyond 23 liters in post dilution, of course, the beneficial effects they play to. So even if I am increasing the dose beyond 23, like I'm making it 30, I may not get more benefits. So the benefits go up in a straight curve, straight rising curve to 23 liters, and then it gets plateaued. So 23 liters in a post dilution field may be the magic number for an optimal dose for hemodiafiltration. And this is the circuit I will be telling you in the video in details. So this is the thing I want to highlight here is that uh, this machine is capable of generating a substitution fluid, but that is with a safety valve. So you can see that in post dilution we have a safety valve. We don't want it to get into some kind of air embolization. So there is a trap, this air trap just beneath the wall, which I will show you in that video in detail. So what clinicians want? This was a real world experience. If you ask nephrologists questions, why do you want hemodiafiltration? What did they say? They said that it is the hemodynamic instability and worsening nutritional status for which they will advise hemodiafiltration. But that is partly true. Hemodiafiltration works well even those who are non-diabetics and who are young patients, those who do not have hemodynamic instability. So the DOPPS data was then refuted by convinced trial which came up in a very recently, and this was a very robust design, and it found the outcome measures not only for all cause mortality but for patient reported outcomes. So the patient reported outcomes were very vital for convinced trial, and as you can see on the screen, the convective dose is 23 liters and the targeted KTORV for high flux dialysis is 1.4. Let us see what happened in the convinced trial. So it was a big trial, 61 dialysis centers across the Europe, which utilized the Bibron machines, which utilized the FMC machines, and it found out that most of the centers could achieve the convective dose. So many of us complain that we don't achieve the dose we have prescribed, but that was not observed in convinced trial. Whatever you prescribed was delivered. And you can see that it is not only the middle molecules. The SDF scores over removal of the smaller molecules compared to high flux hemodialysis. So it's a win-win situation. Not only the middle molecule, but the low flux also more efficient. And the Kaplan-Meier did show that the high dose hemodiafiltration scored better than high flux hemodialysis. But what interested me more is the patient reported outcome measures. So if I ask someone, are you getting better sleep on hemodiafiltration? They will say yes. If I ask them whether your social participation has increased, people on hemodiafiltration, they are more socially active compared to those who are hemodialysis. Their physical function increased, the fatigue came down, and to my surprise, and this study doesn't explain it at the molecular level, but the psychological disturbances like anxiety and depressions were quite better in patients receiving hemodiafiltration. We need to look into this a little closer in coming days. So the conclusions were hemodiafiltration is better compared to hemodialysis. So now when we are convinced that the hemodiafiltration is better, how to start is in our center, in our setup, in Indian context. So I just talked about this in four steps. So the first step is selection of the patients, identify the patient. Then we prepare the protocol. One unit has sort of one protocol. Make sure the water quality is super good. Then we have to execute the protocol with continuous training of your technician, and then we monitor. This slide I borrowed from Dr. Rajiv Annigiri, and he has asked 6 basic questions to clinicians. If the answer is yes, then your dialysis unit is capable of providing online hemodiafiltration. And the crux of this question is as whether you have an access to ultra pure water, whether you are able to do microbiological cultures. So if the answer is yes, please go for online hemodiafiltration. This is just a prototype prescription of hemodiafiltration for chronic dialysis. Please, I make sure that I'm not talking about acute dialysis here. And this is what I want to meant to discuss about the hemodiafiltration here. Let us get back to the video. Thank you so much for your patient listening. Thank you.
Thank you, sir. Thank you so much.
Can I stop my slide share here?
Yes.
This particular mode of dialysis. So we'll go through directly to the machine, we'll see the connectology, and then we connect the real patient on this machine and see how it works. Thank you. Okay. So what we discussed that this particular webinar, we are using less slides and more of real machines. So I want you to visit the B Brown Dialog Plus, which is a hemodiafiltration machine. For this machine, I will give you a tour of this machine. What is the connectology, how it works, and what are the things a nephrologist needs to know before starting a hemodiafiltration therapy. So let us start with the artery. The artery is from where the blood comes to the patient. So the color coding is obviously the red one. Okay. So can you see me? This is the blood pump from which is pumping the blood from the patient towards the machine. And this is the substitution pump. So these are only 2 visible pumps which we can see in this machine, but there are total 7 pumps inbuilt in it, which I will show you one by one. So this is from where the blood is coming from the patient. This is the arterial line. This is the blood pump, and as you can see, there is one port which is lying here, which is the substitution fluid. All right. And this is these are the connections which I am showing you, because this machine is being primed, not being used. Once it is done, I can just drop this leaf here, and this will be the effluent lines. The color coding is white and the blue, from where the effluent fluid will come out, and the machine matches how much fluid is given in and how much fluid comes out. So this is on the blood compartment. Then the blood will get purified through this particular thing, which I can show you. This is the DiaCap Pro. This is the high flux dialyzer. High flux dialyzer is the essential ingredient of any hemodiafiltration process, because this is the dialyzer which withstands the high volume of ultrafiltration, and that is the reason we use this particular dialyzer. And this dialyzer, as you can see, the blood is red, this is the blue, and you can see these 2 ports. These are the dialysis water ports. So we are having 2 types of fluids coming into the machine. One is from as a dialyzer on the other side of the semi-permeable membrane, which is essentially a modified polysulfone material, and second is from the artery. which is here. This is the replacement fluid, or what we say as the substitution fluid. This is before the pump starts, so this is called as pre-dilution. Then the blood will go here, and this is the blue line, which is the venous line, and this will routed here to this chamber. This is the air detector, this is a leak detector chamber, this is the alarm detector. At the same time, you can see one more blue port coming here. This is a substitution fluid which is coming from the another pump. This is the substitution pump. From there, the substitution fluid is coming here, and it will be infused into the patient through the venous line. So we have two places where we can substitute the fluid. One is before the pump, this is called pre-dilution. Next is after the pump, which is called post-dilution. Subsequently, I will tell you what are the advantages and disadvantages. I just want to make you understand that we have two places where we can infuse the water, the ultra pure water, which is converted into a substitution fluid into the patient's bloodstream. That gets ultra filtered here, and the balance is maintained just to avoid the patient getting into hypotension. But when the whole circuit is running, we need very good anticoagulation, which is provided by this slot. This is the heparin slot. And whenever you are using a post dilution, my request is to use a good amount of heparin, and the blood pump speed should be very high, maybe almost 350 ml per minute, to prevent the filtration fraction coming below 20, because that is the point when the circuit will start clotting. So this is the connectology. One more essential part of the connectology is this particular thing, which is called as Sol card, which is the bicarbonate bag, which gives you the alkali which is required to correct the acidosis. This is a particular A can, which will give you the minerals and other electrolytes to maintain the dialysate composition. So this is front part, one portion of the machine. The next portion is your console, which is the touch screen, and we can control this. And how do I do that? This is very simple and very user friendly. So I can do a profiling of the sodium. I can use the conductivity. I can use how much bicarbonate I need to infuse. I can change the dialysate flow. I can change the dialysate temperature also. It gives me a lot of profiling benefits also. The profiling may be customized. Then we can go to the heparins. So I have to first say agree to it. Okay, so next I will go to the heparin slotting. So this is the bolus volume of heparin. So when you are using a HemoDiaFiltration technique, the crux of this technique is combining of the two procedures. One is diffusion, one is convection. That makes the filtration fraction a very important component of this machine. So we need to keep a filtration fraction below 20 as well as good anticoagulation. The next thing what I can show you is this one. This is the ultra filtration profile. So I am putting ultra filtration as 2 liters, but that is above the amount of substitution fluid which I have infused. This is not the substitution fluid. This is above the substitution fluid, and they can measure it to the therapy time. If I put it as 6 liter, this is the patient fluid removal from the patient circuitry. So I have these 6 components which I need to understand before I actually prescribe a HemoDiaFiltration therapy. So this is how it goes. I want to just focus on the KT over V. Even though this is a HemoDiaFiltration machine, we can have small molecular clearance also. But the basic domain where the HemoDiaFiltration works is middle molecular clearance. So we just look at the KT over V, but we focus at the beta-2 microglobulin clearance in this particular machine. So this is the console, this is the hardware, and now I will take you to the back. Very less, with the colony forming units very less than 0.03, 0.01. So these are the army guidelines. But this water is not compatible for infusion into the patients. So what we need to do, we need to convert this ultra pure water into a substitution fluid, with the help of two filters which we call as DiaCap Ultra. So we have two filters here, the first one and the second one, which are in parallel with each other. These are the filters which convert the ultra pure water into a substitution fluid which is compatible for infusion into the patients. So here I want to highlight the difference between a CRRT machine and a HemoDiaFiltration machine. That in CRRT machine we have a finite source of water in form of pre-filled bags, but here the water source is unlimited. As long as this ultra pure water is working and this is giving us ultra pure water, the machine will start giving the substitution fluid. But in CRRT the modality works 24 hours. So the difference between the convective clearance may be matching for these two therapies. But make sure this is an outpatient therapy. So having a convective modality here makes a huge difference, which is also proven by multiple trials. So hello everyone again. I have told you about the connectology when the machine was getting primed. Now I will show how the therapy is actually running, and I will show how the console looks when the actual therapy is running. So let us start from the axis. For this patient, we are having PermCath as an axis. I will definitely recommend for you to have a fistula as an axis, because that gives you adequate amount of blood flow. So blood flow is crucial here, and we have to keep the blood flow about 300 ml per minute. This is to prevent the filter clotting as well as to bring down the filtration fraction below 20%. So from this artery, as you can see, this is the blood pump and I can show you that the blood pump is running at 310 ml per minute. This blood pump speed is matched so as to keep the filtration fraction less than 20%, and I can show you that this blood pump is going here, and we are getting one more line here which is called as the pre-dilution substitution fluid line. So the substitution fluid is being infused in the pre-dilution, and let me tell you why. We look at the patient's profile in totality. The hemoglobin of this patient is 11.3, so that the hematocrit is on a higher side. If I give it post dilution here, I am inviting the filtration fraction to go above 20%, and I am jeopardizing this entire circuitry. Hence, I have chosen to give a pre-dilution at the cost of diluting the plasma. I may get lesser clearance, but at the cost they will be high because I clot the circuit. So this is first part. Second part, this is pump you are seeing, this is the substitution fluid pump. This is giving me a pump speed and giving me a pure water, as we saw in the previous segment of this video, that the substitution fluid is prepared by this machine itself. This is online HemoDiaFiltration. After this, we can see it going into the high flux dialyzer, which is the DiaCap Pro. From here, we are having the diffusive clearance happening also. So we are having two things happening simultaneously. One is the convective clearance with the help of substitution fluid. Second is diffusive clearance with the help of dialysate. After this, we can see that the venous line is going to the venous strap and the air leak detector. I want you to focus on this particular line. This is the line for post dilution, and I have kept it closed. When I am giving a post dilution replacement or post filter replacement, I connect this with these particular lines coming from the substitution fluid pump. So I have three choices with me. First, I can give pre-dilution, I can give post-dilution, I can give both, and they are all controlled by this console. After this, the patient is returned with the purified blood. Now I want to take a look at the console. So this is the home screen where I can show you that the parameters, that time remaining is 2 hours 56 minutes, the blood flow, the heparin rate pump, the ultrafiltration rate which I have set at 2 liters, so this is showing as 500 ml per hour. And I want to take you a journey of what we discussed in the previous segment. So let us go to the dilution part. So this is pre-dilution. We are running the therapy in pre-dilution, and this is the substitution fluid flow rate, which is 80 ml per minute. So 80 ml per minute multiplied by 60 multiplied by 4 comes to 19.1. So this is substitution volume. This substitution volume is nothing but the convective dose of the therapy. And as per the convince RCT, we know that 23 liter is the magic number to have an adequate clearance in HDF for someone receiving 4 hours maintenance dialysis per session 3 times a week. So this is the dose, convective dose. So if you ask me if this particular therapy is giving me only convective dose, my answer will be no. So let us go to the KT overview. So we just saw the convective dose. Now this is the diffusive dose, and I have set KT overview of 1.20 which is planned, but the projective KT overview will be 2.20 at the end of the therapy. So this HDF therapy is not only good for convective clearance, but it will work good for the diffusive clearance also. That is what is shown by the RCTs. Then we have a profiling of the KT overview. Then we have an ultrafiltration profiling here. We can change the profiling which is best suited for the patient. Then we can go to the profiling of the sodium. We have a conductivity, we have a dialysate fluid temperature, dialysate flow we have kept, and this is how we can change the settings for HDF therapy. This is the anticoagulation. My request to everyone who is interested in HDF therapy is to have good anticoagulation, because this particular high flux dialyzer is having a lot of ultrafiltration happening across the membrane. Whatever substitution fluid we are giving, that is 80 ml, and the ultrafiltration of 500 ml. So every that added put together, that is ultrafiltrating here. So the filtration fraction goes high. That is the reason we have to give a good amount of heparin for every therapy, unless contraindicated because of say low platelets or say very severe MBD or something like a hit antibody positivity. Then we go back to the home screen. In home screen, I would like to see you that the TMP, the transmembrane pressure, is just 70. That indicates that our therapy prescription is adequate. Once the TMP starts going beyond say 150, 180, 200, we are inviting clotting or clogging of the filter. So always have a look at the TMP. We have to keep it at a bay so that to run the therapy nicely and to have a great clearance of middle molecules as well as the small molecules. So this is about the therapy. Then I want you to see how it works for the patient. So this is the dialysate flow. I can increase it to a higher level if I want higher diffusive clearance. I can increase the substitution fluid rate if I want high convective clearance. So before starting the HDF, I want to focus on which molecules I want to remove. Based on that, I can change the diffusive and convective clearance best suited for a particular patient. And not only HDF, I can do something called as hemofiltration also. To do that, I just have to stop the dialysate flow, and that will convert into a hemofiltration mechanism, which can be used for high volume hemofiltration therapies, which we do in some selected patients in ICUs. So this machine is capable of giving you a good HemoDiaFiltration for maintenance hemodialysis as well as for few selected patients who are eligible for hemofiltration. Then by looking at this screen, we can see what are the pressure parameters, what time is left, and what is the actual things which are going on. And we can see the color coding. If these lights are glowing, everything is going fine. We don't have any alarms. And as you can see, with the complete machine is controlled by the console, and we don't need to do anything manually. So this was about the connectology of HemoDiaFiltration, and about the concept I have just briefly told you that this is a combination of diffusive plus convective therapies. So it scores better or low flux dialysis, it scores better the high flux hemodialysis. So all these two modalities are superseded by this particular modality, which is a combination of diffusive clearance and convective clearance. That's what we have seen in convinced RCT. This was objective findings, but in subjective findings also, the patient reported outcome parameters were better with HDF compared to high flux hemodialysis. So this is a win-win situation for the patients as well as the clinicians who are prescribing this therapy. So this was all about from my side. Thank you so much.
Thank you, sir. I'll just update our attendees that we'll upload this video separately on the channel so that you can see it again. Moving on, we move on to our next segment. That is the panel discussion. I hope everybody is able to see my screen. Hello?
Yeah, we can see your screen, Purva. No problem.
Yeah. Okay. So good evening, everyone. I am Dr. Purva Bavikar, and I'll be taking you through the panel discussion. For the panel discussion, we have two eminent panelists. Dr. Sourabh Sharma, he is an assistant professor in the Department of Nephrology from Safdarjung Hospital, New Delhi. And he's the chair, also the chair of dialysis working group at the ISN. And the second panelist is Dr. Shrikant Gundlapalli, sir. He's from Asian Institute of Nephrology and Urology, Hyderabad. I welcome you both for the panel discussion. So, Girish sir has already highlighted quite a few important clinical results HDF gives us. But then how are we experiencing it in day-to-day life in our Indian patients is something that is less discussed or the literature is not available. So for that, I would want to first understand that HDF is being practiced only in the metropolitan cities. It is available in my city, but then we are not practicing it as much because of the cost. And although there isn't any study, I came across this slide by Arvind Kanchi sir, which he has quoted from somewhere else, where the main reasons of poor penetration of hemodiafiltration is the cost. And the cost that in Maharashtra, they are being charged rupees 5,000 per session, of which around 2,000 rupees. Are my slides visible?
Yeah, music.
Oh, okay. Seema, can you switch to the next slide, please? Yeah, this cost, yes. So this slide was taken from Arvind Kanchi sir's tutorial. And what he has, this study that projects is that there were patients in which poor penetration of HDF was studied, and the cost of HDF was the factor in which it was leading to underutilization. The cost basically is around 5,000 rupees in Maharashtra. Correct me if I'm wrong. I would like to know the charges in Delhi and Hyderabad. Saurabh sir, Shrikant
Yeah,
sir.
so in Delhi, actually, in government facilities like ours, it is free of cost,
Okay,
and in private hospitals, I think it's same rate.
okay. Sir, in Hyderabad?
Yeah, so our units charge somewhere between 5,000 to 6,600 rupees also in different units based on their quality. The problem is that the insurance companies are not ready to cover this
Yes.
as part of their strategy. So that's the, I think, main hindrance. That's one of the main factors which is preventing, because most of the corporates actually have patients who are insured for maintenance dialysis. So that's one more reason I would say.
Right. So in Maharashtra, we have a scheme called Mahatma Jyotiba Phule, wherein we are providing hemodialysis at the cost of rupees 1,400 per session. And these sessions are done, like there's a cycle of 42 days in which around 18 dialysis sessions are done. So this is at around 20,000 rupees for those 42 sessions. I had a discussion with Bibron and of course with Fresenius also. And what they're trying to do is this Pradhan Mantri Yojana, they are trying to give it for free, but it has not percolated in the other states. I think it is there in Delhi, but it is not in other states. And the cost is the factor because the HDF dialyzers, the one which Sir has mentioned, that is the DiCap Pro, that is around 1800 rupees to 2000 rupees. So that is the cost of electricity and generating ultra pure water is what makes the therapy costly. So as of now, I think all the nephrologists at the metropolitan, cosmopolitan cities have the privilege to do HDF more than the tier 2 and tier 3 cities. Next slide. So keeping that in mind, I'd like to ask my first question to Sourabh sir. Do you recommend starting hemodiafiltration for all patients requiring dialysis?
No, not to all patients, only to selected patients. So in our clinical practice, the most common reason of transition from conventional HD to online HDF is recurrent intradialytic hypotension. That is the most common cause we switch over from conventional HD to HDF, particularly when it compromises the target ultrafiltration or patient tolerability. Also, in some patients with where the middle molecule accumulation is there, like when the patient is having severe pruritus or restless leg syndrome, or there is early signs of dialysis-related amyloidosis. So in those cases, we prefer doing HDF. Not in all patients because of financial restrictions. And we have machines, HDF machines, but as it's provided free of cost to the patients, we cannot provide to everyone because the ratio of HD to HDF is like 10:1.
Okay. Sir, in your clinical practice, what's the most common indication to start? You have addressed this issue, but then is it that you do 3 to 5 sessions and then go back to hemodialysis, or once on HDF, always on HDF?
So we ask because each patient is not on maintenance hemodialysis in our center because our center provides only to the admitted patients because our hospital is around 3,000 bedded and we cannot get a maintenance HD. We only provide to admitted patients. So we ask them to stay on HDF if possible whenever we discharge. And a few of patients who are on CGHS, Central Government Health Scheme, a few of them we provide HDF and do maintenance HDF also.
Okay. Okay. My next slide. My next question, one more slide once again. Next slide. Yeah. My next question is, sir, in order to make the therapy more affordable, can we recommend to reuse the high flux dialyzer in hemodiafiltration therapy? My question is to Dr. Shrikant, sir.
Yeah, I'll take this question, but before that, I have one small perspective regarding the previous question which was asked, which I want to bring about. The trials which Dr. Girish has put in a very, lucid style. I really like his presentation. But the trials also talked about how the advantages of HDF stand out when patients are chosen who maintain a convective volumes of more than 23 liters, as well as younger patients with less cardiac comorbidities. These are the patients in which the maximum benefits of HDF are chosen. That's where the decision becomes a little tricky, because most often, even in our units, like what Dr. Sourabh is trying to tell, we take patients who have poor cardiac condition, who don't tolerate dialysis really well because of the intradialytic hypotensions. But the trials, particularly the previous trials, I don't know about the convinced data, but the initial trials which were done, which were published somewhere in 2013-14, they were only talking about advantage in patients who have younger population who derive the benefit. But coming to the question which has been asked to me, would you recommend to reuse a HDF high flux dialyzer? See, the main concept of HDF revolves around using the good quality water, and like what Dr. Girish is trying to tell, if your unit is able to provide that quality of water, then it is the right time for you to choose HDF. Our unit has around 20% of the dialysis in our unit are HDF, because it's a private unit. Patients are able to afford. We choose them, we give them as the first choice. So we don't reuse high flux dialyzers at all. And I would strongly suggest against it. Even KDIGO and the guidelines are against it. Do you practice hybrid RRT in your practice? For example, session of HDF and 2 sessions of HDF. Yes, that is often done to some of the patients, but I don't really believe they are benefiting. We are also doing it in certain patients only self due to financial constraints, but I don't think it is a right practice to do. If the patient is able to afford, and if the patient is a candidate for HDF, I think that you lose the advantage of taking HDF if you choose to shift into HD modalities in between. The convective volumes of 23, the whole concept of benefit revolves around the convective volumes of 23 liters per session 3 times a week. So if you are not able to deliver that, then the advantages become very, very low. So I would, we are doing it, but I don't think that's a right strategy personally.
Right. So my next question is to Girish sir. I have not had the opportunity to put it as a slide, but how much heparin do you recommend? Is it the same as hemodialysis or?
Yes, absolutely. We
Yeah,
are
100
we are
ml.
using
Okay.
almost 10,000s
Okay.
of heparin per session. The bolus
Mm-hmm.
is usually 2000 unit. It is the bolus, and the rest of the given as an infusion. But it
Okay.
depends on the patient profile actually. So if so, for example, we have a very low platelets or a borderline platelets, somebody who has recently got on a dual antiplatelets. So all these things come into play when we are prescribing heparin. But yes, heparin is a must for hemodiafiltration.
Right. Sir, as Shrikant sir mentioned, the convince trial was done more so in the young patients, like in the younger
Yes,
population,
yes,
and
yes,
get better outcomes. But
yes.
the question is that we usually have patients who are frail. So, and unless and until there's a study done on those kind of patients, we'll never be able to know if HDF is actually working. But when they did this head-to-head trial wherein they have compared high flux hemodialysis with compared to hemodiafiltration, as of the tier 2 cities or by and large where hemodialysis is being used commonly, how much do you think that we are at a disadvantage by not using hemodiafiltration?
See, I'll just take you back to the Convince trial. It started in 2018 and the
Right.
study was freezed in 2021. So it's a long duration study. And
Right.
while conducting the study, the investigators were not sure which patients will get benefited. But when they did subgroup analysis, they found that people who are non-diabetics and people who are younger in age group, they benefited the most.
Hmm.
So actually, we are using HDF when the HD is not giving us the outcomes we desire, but it is other way around. HDF should be a by default prescription whenever who is somebody is going on dialysis. So that is the kind of thinking presently which is evolving. But then the cost angle comes in play in Indian context. So that may be a difficult proposal for our patients. But the studies are quite mute about doing hybrid HD plus SDF. There is no data. We do it because we have to do it.
Right.
Girish,
So
So
my
comments on the extended hemodialysis as what has been talked about by these people from Baxter. They do the
yes,
high flux hemodialysis, which can be used in a normal machine without ultra pure water. So does it
yes.
provide enough advantage with respect to middle molecular clearance?
No, sir. It was definitely shown in Convince trial, in Ishol trial also, that the high flux hemodialysis is not sufficient for removal of middle molecules. Unless we have a convective clearance, the middle molecules will not be cleared from the bloodstream. They found the sieving coefficient of beta 2 microglobulin 0.7 to 0.8 in hemodiafiltration. It was far low in hemodialysis. So unless we have a convective clearance, I think middle molecules will not be cleared. I mean that is my understanding.
I agree with you.
right.
Even hemodiafiltration, the parameters are quite strict, even if you do You have to achieve 23 liters of, we are doing 5-hour sessions for these patients because most of our machines are on auto flow setting, which
Yes.
achieves somewhere around, this we use Fresenius machines, which have auto flow. See, the auto flow achieves somewhere around 80 ml clearance per minute convective volumes. We don't set
Yes.
anything in that.
Yes.
You need to do it for at least 5 hours because most of our fistulas or access have a blood flow of around 300 ml per minute, not more than
Yes.
that. So with that, we are doing at least for 5 hours for sessions to achieve the convective clearance of 23, 24 liters. Otherwise, you'll not be able to achieve so much convective clearance.
Saurabh, your thoughts on this?
Yes, sir, I agree with you. Actually, totally agree with you, sir.
Hello. Yeah. So my next question is to Dr. Saurabh. So how frequently do you check beta 2 microglobulin for a patient already on HDF?
So to be honest, we do not routinely monitor beta-2 microglobulin in patients already on HDF. Once a patient shifted to high efficiency HDF, particularly post dilution with high convective volumes of more than 23 liters, we assume adequate beta-2 microglobulin clearance, especially when the clinical signs like the pruritus and the bone pain, these are stable or improving. And in selected patients, those with suspected dialysis-related amyloidosis, unexplained musculoskeletal symptoms, then we check beta-2 microglobulin once or twice a year. But in general, it is not a part of routine monthly labs. So that's how we check it. And regarding the next question, regarding the convective dose, we aim a convective volume of at least 23 liters per session, as Girish sir has already talked in his slides, and in post-dilution online SDF, which aligns with the current evidence from CONVINCE and SOL trials. And this threshold appears to be to see the cardiovascular and survival benefits. And the studies have suggested that the higher the convective volume, if it's more than 25, the better are the outcomes, provided we maintain good vascular access and session duration. So for chronic HDF patients, our goal is more than 23 liters per session, which often requires a blood flow rate of 350 to 400 ml per minute, and the treatment time of at least 4 hours.
Right. There's a question from Dr. Akshay Kulkarni. He's asked, what is the benefit of hemodiafiltration in patient with shock, where CRRT is not affordable or available? Requesting comments from experts.
So in my point of view, in shock, we should do SLED. What we do cannot achieve HDF in those cases because the blood flow rate of 350 400 is not achievable. So in those cases, we prefer SLED or CRRT as per the patient profile. And what's your thought, Girish sir, Shrikant sir?
Yeah, see, this is one of the commonest questions which are asked in such discussions. So I feel we have to bring in 1 or 2 points in this. One is reducing the dialysate flow can happen in 5008S machines below say 200 ml per minute or so, which cannot happen in the standard 4008S machines. That is one of the reasons why some people tend to use this machine, though it's not a replacement for CRRT. Some people tend to use it for keeping low dialysate flows, which may make sure that the dialysate clearances are less. And like what Dr. Sourabh is pointing out in such a scenario, the advantage of HDF, which is supposed to clear the middle molecules. The machine is meant for that. Using a high flux machine is meant to clear the middle molecules, which has some role in sepsis by clearing the interleukins and cytokines. But using such convective volumes is not feasible in patients who are already in shock. So there's a clinical dilemma there of getting an advantage, but not being able to use it because of shock. If you are using the machine to keep low KT over V's so that your patient's pressure do not fall rapidly, because this one advantage of CRRT would be to keep the low clearances over long periods. Yes, you're going to use it. So in a setting where you don't have a CRRT, I think using HDF machine, that is 5008S, we are not talking about HDF as clearance. Using a HDF machine to achieve low dialysate flows would be a reasonable option. I request Girish to comment on this if there is anything else that he can add to.
Yes, sir. See, CRRT studies, they have shown the benefits within a range of 25 to 30 ml per kg per hour as a delivered dose. That's what the studies say. If we extrapolate this understanding to hemodiafiltration, the dose of hemodiafiltration and the concept of hemodiafiltration is same as CRRT. It is convective plus diffusive. But if you calculate the effluent dose or the convective dose here, there is fundamental difference. The hemodiafiltration studies are talking about convective dose, which talks about the substitution fluid infused in liters over that 4 hours or 6 hours of period. It doesn't consider the dialysate flow. In convective dose of SDF, it is only the substitution fluid, but in CRRT, we talk about effluent dose. It is not the convective dose in CRRT. So effluent dose is the replacement fluid plus patient fluid removal plus dialysis fluid. So if you do the same calculations for HDF, and if you continue the HDF machine for say 24 hours with some breaks in between as the machines demand, what we end up doing is a CRRT, but it is the high volume HDF. So it is the CRRT, but the dose of that CRRT will be somewhere into say 80 to 100 ml per kg per hour. And the data says that there is an inflection point, just like convective dose of SDF. After increasing the CRRT dose beyond 40 ml, the benefits are there are no much benefits after it. So if the concept may be the same, but when it comes to dose delivery, I think these two modalities are entirely different in acute dialysis.
Sir,
They can't replace each other. I mean, and up till now, all the studies of hemodiafiltration are for chronic dialysis. No study talks about acute dialysis using hemodiafiltration as a methodology, because I think the investigators are also very clear that a long duration of hemodiafiltration is nothing but high volume CRRT. I think that's what I think.
right. Sir,
Yeah,
Dr.
totally agree, sir.
Kalra,
Yeah, Sourabh,
Sorry,
please.
ma'am. Sir,
uh,
actually, I totally agree with you because in a condition of shock, what we are achieving is totally different. What we need to achieve is totally different. We do not need the to adjust the symptoms of the patient. We are not addressing the symptoms. We are addressing the acute condition, whether the patient is
Yes.
in sepsis. So the need is totally different.
how will reducing the blood flow rates in HDF affect the therapy session? Girish sir, Shrikant sir, Sourabh sir, anybody?
So if you reduce the blood flow, the total, see, if the total clearances are low, the convective doses also become automatically low in these patients, because as I told, Fresenius machine, we don't have B Brown machines. Fresenius machines has a complex setup, but if you set the auto flow, you don't need to do a lot of things. So what happens is, if your blood flow is 300, it sets a convective volume which is say 1/4 of it, somewhere around 80-75 ml per minute. So that way you're achieving good convective volumes by having a good flow in the QB, the blood flow. So if your blood flow is low, your convective volumes are low, your advantage of doing a HDF in this patient is already gone.
So that again, we cannot use HDF in acute conditions, as Dr. Girish has already mentioned. Dr. Kalra here writes, would it be right to say HDF is more metabolically friendly with diabetes?
We couldn't hear you, Purva, right, actually.
Girish?
The question basically is whether HDF
He
is
has,
more
Dr.
metabolic
Kalra has
friendly
written,
and can
would
be
it be
used.
right to say that HDF is more metabolically Are we audible, sir? Hello?
Yeah, I
Yeah,
can
yes,
hear.
ma'am.
Hello?
So, actually, I would like to answer that. So we can, it's a good term, sir. So Kalra sir has suggested a good term for HDF, metabolically friendly HD, as there is superior middle molecular clearance and there is better phosphate control. And as sir has already discussed regarding the nutritional status, we are preserving the nutritional status in HDF and improving the hemodynamic stability. We are decreasing the inflammation, chronic inflammation. So it's a good term to call it uh, metabolically friendly HD. So that's a good term for HDA. What's your point of view, sir?
That's quite perfect. That's quite perfect. That's quite perfect. So our focus in uremia is now shifting from the after the LTOX trial from the small molecules to middle molecules, and probably now we are looking at better quality of life than longevity. So that is what we are trying to achieve in these kind of patients. Here I would like to take Dr. Rishi Deshpande sir's question. Sir has just put a question that what is experience with HDF in ACLF in ICUs.
They were
So
failing.
if somebody Shrikant sir, can you just comment on this?
Unfortunately, I don't have experience in that regard. But I think it would be similar to what has been discussed with respect to sepsis and shock. Dr. Saurabh, can you comment?
So actually, we have not used in liver failure cases, acute on chronic
Yeah.
liver failure cases. But what I presume is that these cases are having uh, massive ascites, and in these cases, we when we do HD, conventional HD, there is dialytic hypotension. It's more in these patients as compared to other maintenance HD patients. So it will be better to maintain the blood pressure interdialytically. So I presume that it would be better to do HDF as compared to HD.
Right. So next question is to Dr. Shrikant. Sir, do you consider hemodiafiltration as a, do you think they deserve a trial wherein sir mentioned there are mini CRRTs happening throughout?
This question has been extensively discussed. I think like what Dr. Girish is pointing out, the clearance volumes will be very high in HDF vis-a-vis a CRRT, making this modality unsustainable when it is used as a complete HDF machine. But if you are using it to only reduce the blood flow, the dialysate flow rates vis-a-vis a standard HD machine, and if you do not have an access to CRRT, then I think that would be a reasonable choice. But I do not agree that it can be a replacement for CRRT in any regard. Now, when do you switch to HD? After HDF, I think once you switch back to HD, your advantages of like cardiovascular, that interdialytic hypotension risk, the quality of life, the phosphate control, everything would be lost. So unless there is some compelling reason, like a financial reason, I would not consider shifting any patient back to HD.
Okay.
I
So my next
one point, sir. One point, ma'am. So in what we have seen in these patients on HDF, whenever they have compromise of vascular access and we are not able to maintain blood flow above 300, or there is recurrent filter clotting or alarms, in those cases we do switch over to HD. Apart from what sir told.
right. So my this session's last two questions are to Girish sir. Which candidate should be prescribed pre-dilution substitution over post-dilution substitution?
So up till now we have discussed the holy number of 23 liters. The holy number of 23 liters is studied for post dilution hemodiafiltration. When you are using it pre dilution, the rule of thumb may be multiplied by 1.3. So you can use a pre-dilution for patients who have a high hematocrit, like a hemoglobin of say more than 12. Those who have something like a hyperparaproteinemia, those who have hyperviscous blood, people with say hypertriglyceridemias. These are the candidates whose baseline blood viscosity is high. So you can't risk them having a post dilution hemodiafiltration. Better to use a pre dilution. But at the same time, we cannot risk the lesser clearance in pre dilution mode. So the convective dose goes up. So it is almost 26 to 28 liters when you are using pre-dilution, because the plasma is obviously diluted. But in pre-dilution, we are a little safe that the circuit will not clot. For example, a patient has a low platelets and you are not able to give a good amount of heparin. So I would prefer to give lesser heparin, but in pre-dilution. So these are the patient cohorts I will choose to give pre-dilution. Your next question is very interesting, that what I should do for chills and rigors. See, if I am confident about the water quality, I won't panic, because that's not because of the water itself. So I will look at the access, and as a good access is a prerequisite for HDF, I think if the access part is sorted out, I will look for other causes of fever, other causes of chills in this particular patient. I won't blame the therapy immediately unless all these things are in place: a good access, a good water source, and a good technique. That's what I will see. The third is thrombosis or bleeding. So I am more worried about thrombosis than bleeding. So my choice will be to give good amount of heparin, good amount of convective clearance, and see that the filtration fraction comes below 20, so that I will be able to deliver a good dose of HDF.
Right. Sir, I'd like you to do the closing remarks for the session today.
Okay, so the honor is all mine. So thank you so much, Shrikant sir. It is always wonderful to listen to you. We have learned a lot from you. Thank you, Sourabh sir. It's always pleasure meeting
sir.
you, and we'll keep discussing about SDF. Thank you, Suhas. Thank you, Purva, and thank you, Rishi sir. Thank you, Abhishek. So there are all familiar faces today. So I think we'll take this forward, and let us continue this Nephrocon webinar for coming months and years to come. So thank you so much, and a very good night to you. Thank you.
Thank you, Girish.
Thank you, sir. Thank you, ma'am.
Thank you. Thank you.